Most clinicians use standard tools to perform sleep apnea screening, but could further automated analysis of these sleep studies to lead to better patient outcomes? The main aim of this presentation is to highlight some of the clinical tools already available in cardiorespiratory screening studies and their impact on the diagnosis and management of the patient. We will show how to record these signals from existing equipment and sensors, how to analyze these signals using automated tools, and how to use the results to improve the patient's treatment. So today, we will learn about 3 unique modules in the EMBLA RimLogic software. The respiratory mechanical instability, the pulse transit time, and the Cheyne-Stokes breathing. Respiratory mechanical instability, or the RMI, and how it may help determine the optimal pressure of CPAP, as well as the classification of respiratory events. The AASM recommends recording the intent to breathe through measuring the thoracoabdominal efforts by using the respiratory inductance plethysmography sensors, which detect the expansion of the chest wall and abdominal circumference, reflecting the attempt to increase in volume of the thorax by muscular effort. As the diaphragm is stronger inspiratory muscle in comparison with the intercostal muscles, and as there is a limit to the maximum pressure change in the thorax, obstruction often leads to paradoxical movement of the chest and abdomen, where the abdomen increases in circumference while the chest decreases. It's recommended to place the thoracic rib belt on the level of the 5th and 6th ribs due to the greater radius of curvature that results in a maximum lateral expansion and better detection of the signals. Abdominal rib belt is to be placed on the umbilicus region. When we use the rib belts, the thoracoabdominal effort traces are recorded. RimLogic also can derive extra traces like the following: xsum, xflow, that represents the time derived of the sum of the thoracoabdominal effort that can be used as an alternative to the nasal pressure and thermal signals. RMI and phase will be discussed in the following slides. Phase is the result of the difference of the sinusoidal traces of the thorax and abdomen, and it is expressed as an angle using degrees as unit. The total values for phase shift between abdomen and thorax can mathematically vary from 0, that is total synchronicity, up to 180 degrees, that is complete paradoxical out of phase breathing. Actually, 0 degrees sounds not physiological because the abdominal effort typically is a bit earlier compared to the thoracic effort. Hence, the phase is usually few degrees positive in physiological breathing. When the phase trace is higher than a certain threshold for more than a minimum duration of time, a paradoxical event is added to the recording. In this slide, we have the snore channel, the CPAP flow, thoracoabdominal traces, phase, and RMI. Looking at the CPAP flow, it's evident that we have a sinusoidal breathing pattern with no distortion on the peak flow, which already has a normal contour. Thoracoabdominal effort shows synchronized breathing pattern. Looking at the phase, we can see that there is no change in the phase signal. Therefore, no RMI events were detected. In this slide, we have the snore channel, nasal pressure, thermistor, thoracoabdominal traces, phase, and RMI. Looking at the thermal signal, it's evident that there are no apneas. Looking at the nasal pressure, it is obvious that there are hypopneas. Thoracoabdominal effort shows desynchronized breathing pattern, which gives an indication that these are obstructive hypopneas. Phase trace shows associated changes in the angle of phase signal, and RMI events were detected. In this slide, we have the snore channel, SpO2, nasal pressure, thoracoabdominal traces, phase, and RMI. Looking at the nasal pressure, it's evident that there are hypopneas. Thoracoabdominal effort shows synchronized breathing pattern. Looking at the phase, we can see that there is no change in the phase signal. Therefore, no RMI events were detected. RMI helps in subclassifying hypopneas, which in turn would impact the diagnosis and the treatment. In this slide, on the top, we have an overview for the RMI trace. The view shows that the RMI index is very high during the first part of the study, which indicates severe obstructive sleep apnea syndrome, while it becomes lowered till the end of the second part of the study, except in subparticular locations that can be related to REM sleep or supine position. The blue vertical bar represents the current time on the worksheet, where we have the SpO2, snore, thermistor, thoracoabdominal traces. Looking at the thermal signal, it's evident that there are no apneas. Looking at the nasal pressure, it's obvious that there are hypopneas. Thoracoabdominal effort shows desynchronized breathing pattern, which gives an indication that these are obstructive hypopneas. In this slide, on the top, we have the hypnogram. An overview for the RMI trace and pressure monitor. This is a split night study. The view shows that the RMI index during REM stage at CPAP 6 is high, which indicates severe obstructive sleep apnea. The blue vertical bar represents the current time on the worksheet, where we have the snore, SpO2, CPAP flow, thoracoabdominal traces. Looking at the CPAP flow signal, it's evident that there are neither apneas nor hypopneas. However, flattening of the contours of the peak flow signals is present. Thoracoabdominal effort shows desynchronized breathing pattern, which gives an indication that this pressure setting is not optimal for treating the condition. In this slide, on the top, we have the hypnogram, an overview for the RMI trace, and pressure monitor. This is a split night study. The view shows that the RMI index during non-REM stage at CPAP 6 cm H2O is normalized. The blue vertical bar represents the current time on the worksheet, where we have the snore, SpO2, CPAP flow, thoracoabdominal traces. Looking at the CPAP flow signal, it's evident that there are neither apneas nor hypopneas nor flattening. Thoracoabdominal effort shows synchronized breathing pattern, which gives an indication that this pressure setting is suboptimal for treating the condition. In this slide, on the top, we have the hypnogram, an overview for the RMI trace, and pressure monitor. This is a split night study. The view shows that the RMI index during REM stage at CPAP 8 cm H2O is high, which indicates severe obstructive sleep apnea syndrome. The blue vertical bar represents the current time on the worksheet, where we have the snore, SpO2, CPAP flow, thoracoabdominal traces. Looking at the CPAP flow signal, it's evident that there are neither apneas or hypopneas. However, flattening of the contours of the peak flow signals is present. Thoracoabdominal effort shows desynchronized breathing pattern, which gives an indication that the pressure setting of 8 cm H2O is not optimal for treating the condition. In this slide, we have the snore channel, SpO2, nasal pressure, thoracoabdominal traces, phase, and RMI. Looking at the nasal pressure, it's evident that there are apneas. Thoracoabdominal effort shows absent effort throughout the apnea periods. However, due to the physiological cardioballistic oscillations represented as small humps during the absent effort period, the phase shows that there is a change in the phase signal. Therefore, associated RMI events were detected. This is the only limitation of the RMI. However, if we correlate the RMI with the SpO2 overview, we can overcome this limitation, as it's well known from the literature that the flow of oximetry graph for central sleep apnea has a unique characteristic pattern, which is low to moderate repetitive desaturations in non-REM sleep that appears like a sawtooth pattern. AHI is recommended measure to evaluate the severity of the respiratory sleep-related disorder. However, the RDI gives more insight to the severity of upper airway resistance syndrome as it considers respiratory events-related arousals. RMI is even more sensitive than RDI as it considers flattening that are not associated with arousals. In REM logic, RMI can also be reported in relation to sleep stages and body position. Furthermore, this measure can be reported per each pressure settings of titration studies in order to be able to identify the optimal pressure of titration. The next module is the pulse transit time, and we will learn how it may assist detection of narcolepsy and periodic limb movements. Pulse transit time, or PTT, is defined as the time that takes a pulse wave to travel between the aortic valve to the periphery, and it is calculated as the interval between the ECG-R wave and the subsequent arrival of the pulse wave at the finger. Usually, this arrival is identified with the point on the pulse waveform that is 50% the height of the maximum value. PTT is a sensitive tool for measuring transient changes in the autonomic tone. For practical reasons, the opening of the aortic valve is assimilated to the R wave on the ECG. The speed of this wave is directly proportional to the inverse of the systolic blood pressure. Thus, a slight increase in the blood pressure causes an increase in vascular tone, which in turn stiffens the arterial wall, causing the PTT to shorten. That is represented as a transient dip in the baseline of the PTT signal. An increase of PTT reflects an increase in respiratory effort. There are three methods to evaluate inspiratory effort in sleep: the thoracoabdominal rib technology. This technology allows semi-quantitatively measurements of the tidal volume during sleep. The relationship between tidal volume and rib, however, may change with changing body positions during sleep period, and in case the belt slipped during night, this can result in inaccurate measurement of the effort. The second technique is the esophageal pressure. It's considered as a gold standard as it measures the fluctuations in a pleural pressure. However, this technique is invasive and also expensive. PTT signal provides an invasive measure of the inspiratory effort and microarousals that can be used to document obstructive sleep apnea syndrome. It requires recording ECG in order to recognize the R wave, and the pulse oximeter to analyze the photoplethysmography signal, assessing the arrival of the pulse wave to the periphery. As per ASM recommendations, PTT has a high sensitivity and specificity in distinguishing between central and obstructive apnea-hypopnea, and may be used if the esophageal pressure monitoring is not available. In analyzing the trace when blood pressure is not monitored, the only tool used to identify the microarousals is to observe a depth in the PTT amplitude for a duration of approximately 8 to 15 milliseconds during stage 2 sleep. However, during REM sleep, variations in sympathetic activity are spontaneously very high, and therefore the PTT baseline is highly variable. Thus, the recognition of true microarousals during REM sleep is a lot less specific than in other sleep stages. PTT can be used to analyze respiratory events and specifically to detect hypopneas, upper airway resistance syndromes, and central events. Because the heart and the vessels are located in the thorax, therefore, these organs can also be affected by variations in the thoracic volume and pressure as a result of breathing. As the thoracic pressure increases, the heart is compressed and blood pressure increases and PTT shortens. In this example, flow shows 3 events. The first 2 events have slight reduction in the amplitude that are not hypopneas. To score them as respiratory event-related arousals, correlated arousals should be present. In polygraphy studies, EEG is not recorded. If you have PTT signal, which is in the bottom, it will show a correlated arousals, and as it increases till the event is terminated, this indicates that these events are obstructive. In this example, there are 3 respiratory events. These events are hypopneas, and the esophageal pressure shows a reduction in the pleural pressure, which is an indication of a central pathology. As in obstructive events, the esophageal pressure increases until the event is terminated. On PTT, it is obvious that there is a reduction during the central event in a similar fashion to the esophageal pressure. So, PTT is a useful tool to differentiate between the central hypopneas and the obstructive ones. In this example, flow shows a normal sinusoidal breathing pattern with normal and no fluctuations in the esophageal pressure. That is a strong evidence of no upper airway resistance syndrome. However, the PTT trace shows a depth in the signal for more than 8 to 15 milliseconds, which is a typical representation of the autonomic microarousals, which are correlated with the repetitive stereotypic movements seen on the leg EMG trace. In this example, esophageal pressure manometry, effort, and flow show no respiratory related pathology. However, the PTT signal shows repetitive transient depths as an indication of microarousals. In the absence of periodic limb movement disorder, this can support the diagnosis of narcolepsy in conjunction with other findings and clinical history. In this example, we have the neurotraces that are displayed over 30 seconds, while respiratory traces are displayed at 5 minutes. The black bar is called the indication bar, and it is used to synchronize the time between the two worksheets. The indication bar is preceded by an obstructive hypopnea that is associated with an EEG arousal. This is also supported by the PTT signal that shows a correlated dip in the amplitude as a sign of an arousal. Furthermore, it increases till the event is terminated. This fashion supports the diagnosis of obstructive pathology. The third module that we will be discussing today is the Cheyne-Stokes breathing module, and we will learn how it may help select the therapeutic modality. As per the ASM recommendations, a CSB event is scored when we have a minimum of 3 consecutive central apnea or hypopnea, when there is a crescendo-decrescendo breathing pattern, and when the cycle length between two different events is 45 to 90 seconds, then we can register a CSB event. Cycle length is measured from the zenith of the inspiratory portion preceding a central apnea or hypopnea till the zenith of the inspiratory portion following a central apnea or hypopnea. This would be time consuming if you don't have an automatic module to correlate all of these events. CSB module is an algorithm that detects the typical crescendo and decrescendo waveforms in respiratory recording traces related to the airflow and breathing efforts of a patient using one of the following signals: thorax effort, abdominal effort, X-sum, and X-flow. The CSB analyzer in RimLogic scores the following events on a specified trace: the apneic phase, hyperapneic phase, CS cycle, and CSB sequences. The apneic phase represents the pause or the reduced ventilatory effort period on the flow channel, while the hyperapneic phase reflects the resumption of normal breathing. Crescendo and decrescendo pattern of breathing. Crescendo is identified as the duration from the resumption of breathing following an event that continues till it reaches the zenith of the inspiratory portion, while crescendo represents the period from the zenith of the inspiratory portion till the beginning of the next episode. CSB sequence has to be composed of at least 3 central apneas or central hypopneas with a cycle length of 45 to 90 seconds. Cheyne-Stokes cycle is defined as the cycle length itself. In this example, we have more than 3 central apneas with a crescendo-decrescendo pattern, and the automatic module was able to detect the CSB parameters on the X-flow as predefined. In this example, there are more central hypopneas, and the module was able to detect the CSB parameters on the X-flow as predefined. RimLogic has an embedded report section on CSB that uses the results from the phase desaturation association to calculate circulatory delay statistics for reports. The following parameters are reported: CSB percentage, number of CSB sequences, number of Cheyne-Stokes cycles, longest and shortest CSB sequence. Using RMI, PTT, and CSB can help in distinguishing central pathology, which influences choosing the best treatment modality, as well as detecting the optimal titration pressure of that selected modality. Thanks for your attention.